Welcome everyone to the Network for Public Health Law webinar, Counting Everyone, Counting Correctly. I'm Kayleen Clarich. I'm Associate Director of Communications here at the network. A couple of housekeeping things before we get started. The webinar is being recorded, as you heard, and you will receive an email when the recording and the slides have been posted to our website. Feel free to use the Q&A function throughout the webinar if you have questions, and we'll try to get to as many of your questions as possible. And now I'd like to pass it on to our moderator for today's webinar, Megan Mead, who is Deputy Director of the network's Mid-States region. Megan.
Okay, thanks, Kayleen, and welcome everyone to our webinar. We can go ahead and go to the next slide. First of all, I do need to share our legal disclaimer. Here at the network, many of us are attorneys. As we like to say, we may be attorneys, but we're not your attorney. So the information that we're sharing today is for informational purposes only. And for specific legal advice, please consult with your own legal counsel. Next slide, please. In addition to this webinar today, there are many different ways that you can connect with us here at the Network for Public Health Law, and there's lots of support that we provide, including free legal technical assistance and a wealth of resources on our website. So if this is the first time that you're learning about MPHL, your first time at one of our webinars or connecting with us, we encourage you to check out the website and learn more about how we can support your work. And if you're already familiar with the Network for Public Health Law, this is hopefully a helpful reminder of the wide number of ways that we can support you in your public health work. So please take a look, reach out. As I said, we do also have free legal technical assistance. Next slide, please. And here are our stellar lineup of speakers for today. I'm actually going to go bottom to top because that's the order they'll be speaking in. We have Shannon Piccolo, who is a senior attorney here at the Mid-States region of the Network for Public Health Law. And then we have Jamie Piat, who is an epidemiologist and evaluator with the Southern Plains Tribal Health Board. And then we have Brian Huey, who is a staff analyst at the Center for Health Equity at the Los Angeles County Department of Public Health. Next slide, please. And just to give you a brief overview of where we will be headed and what we hope you will take away from today, we expect that you will leave with a better understanding of the foundations of data disaggregation and how it can promote health equity. You will learn about challenges associated with aggregated race and ethnicity data and then its associated impacts when it's aggregated. You'll obtain strategies for more inclusive data collection, tabulation, and visualization. And then you will also learn about the impact of racial misclassification on marginalized populations, with a particular focus on American Indian and Alaska Native data accuracy and reporting. And without further ado, I am now going to turn it over to Shannon to kick us off with the presentations. Thanks, Shannon.
Thanks, Megan. Hi, welcome everybody. My name is Shannon Piccolo. I'm with the Network for Public Health Law, and I'm just going to provide a sort of broad overview today with regards to data collection authority and a little bit about data disaggregation. So we're just so all of us are on sort of the same playing field before Jamie and Brian do their presentations. Next slide, please. So states, territories, local health departments, and tribes all have the primary responsibility for protecting public health, and this includes the authority to collect data. States regularly require reporting of key data elements from healthcare providers and laboratories based on reportable diseases and immunizations, and often race and ethnicity data fields are commonly required. However, these categories and the level of details vary by jurisdictions. The federal government also influences data collection. Federal agencies may condition funding on requiring data reporting. CMS mandates reporting of race and ethnicity data. The OMB Directive 15, which was also updated on March of 2024, sets federal agency standards for race and ethnicity data collection and reporting. While not binding on stilts, Directive 15 often guides states' data collection practices. However, as Jamie and Brian will explain in their presentations, these standards also often fall short in capturing meaningful racial and ethnic diversity. Next slide, please. The law generally supports the collection of race and ethnicity data in public health. However, HIPAA is often cited as a barrier to data collection and reporting, but HIPAA expressly allows disclosure of identifiable information to public health authorities. Covered entities may rely on the public health authority's determination that specific race and ethnicity data is needed, which complies with the HIPAA minimum necessary rule. And also the ONC has also clarified that failing to report required public health data as requested by a public health authority may constitute impermissible information blocking. Next slide, please. Although the law generally supports data collection, several non-legal barriers undermine the consistent collection of high-quality race and ethnicity data. Data collection typically occurs outside of stilts in providers, hospitals, laboratories, which create challenges for standardization. Patients may be hesitant to disclose race and ethnicity if they do not see themselves represented in categories or are limited to only selecting one. They may also not trust where and how this data may be used. Providers and hospitals may be hesitant to ask questions, may leave fields blank, and they may make incorrect assumptions. Race and ethnicity categories are not consistent across reporting and collection systems, requiring stilts to reconcile and combine data. Programmatic and technological silos across public health systems result in multiple data sets and standards, and reconciling these resources is resource intensive and time consuming that often stilts do not have. Finally, data collection methods and categories used directly influence which groups are visible in our public health data. Inaccurate and inconsistent categories can lead to misclassification, erasure of communities and multiracial populations, and inconsistent data that undermines the accurate reporting and equity efforts. Next slide, please. Data disaggregation is the breakdown and categorization of large sets of data into certain data elements, and we're going to talk specifically about race and ethnicity here today. And data disaggregation can reveal inequities, provide more complete data, improve actions, promote inclusion, and help build trust. Every individual and every race and ethnic group has a right to be counted accurately. And this principle is reflected in the efforts that Brian and Jamie are going to be here presenting to you today. I'm going to send it over to Jamie.
Hi.
Oh, just, oops, I forgot. Oops, sorry, Jamie, I forgot one more slide. Just to let everybody know, the network does have a handbook on disaggregation of public health data by race and ethnicity, and we have a link here. So, sorry, Jamie. No, go for it.
Thank you. And I'd like to thank the MPHL for inviting me to speak and all of you here who are joining this webinar. So I'm sure you're all familiar with the term racial misclassification and what that entails. And I hope after this, you'll see some of the implications it has on the American Indian, Alaska Native population, how profound it is, and the impact on data and its integrity. I will discuss a project we're currently undertaking in hopes of mitigating it in Medicaid data. Next slide, please. I won't go into great detail, as I'm sure many of you are familiar with racial misclassification to some extent, as I stated previously, but it's a big issue facing American Indian, Alaska Native data. And the more we investigate, the more we cannot underestimate its impact. I apologize if you'll, I have some bullet points. If you'll scroll, hit it again, it'll show up the bullet points. You may have to hit it a couple. Yeah, there you go. Thank you. I think there are 3 bullet points on this. Thank you. So what is racial misclassification? It's the incorrect recording of an individual's race or ethnicity, for example, American Indian as white or some other race. And it usually occurs in one direction. So an American Indian may record it as another race, but that other race is often not recorded as being American Indian. And as we know, accurate and reliable data are crucial to understanding the population burden of disease and injury, identifying disparities among population subgroups, monitoring trends over time, and prioritizing programs and resource allocation. Misclassification of race is a significant problem when describing health disparities and equity. correct data are paramount for many decisions, including appropriately sourced funding, organizational processes, and quality measures. This has been problematic for the AIAM population as they are often racially misclassified in data sets that are crucial for decision-making. Furthermore, AIAN data may altogether be omitted from data reporting, and this complicates outreach efforts to a historically marginalized population. Next slide, please. Thank you. As we began to investigate racial misclassification and its impacts, we've looked deeper to try to understand how it is occurring so we can help address it. So far, we're seeing it occurs when data are collected, analyzed, and reported. Our group has previously looked at, and we continue to address racial misclassification and mortality data. That's kind of what started us down this endeavor. Anecdotally, we hear about racial misclassification all the time in many data sets, and it seems the more we look, the more we find. But the thing about mortality data is that we can actually quantify its existence, and I'll explain how in the next slide. So next slide, please. Thank you. We have more contextual knowledge around racial misclassification in Oklahoma due to a study conducted by my organization, the Southern Plains Tribal Health Board, and the Oklahoma Health Sciences Center. And what they did is they looked at enhanced link data, which is vital statistics data that have been linked with Indian Health Services data. And this study found that in Oklahoma, 20 to 40% of American Indian Alaska Native and Alaska Native individuals were misclassified in mortality records. Now that it seems wide 20 to 40%, but actually it depends on the region where the mortality occurred. And what they found was that in more rural areas, people were less likely to be misclassified. And that was due to tribes often having a relationship with the funeral home and the funeral home being familiar with the tribe and their practices. Whereas in more urban areas, racial misclassification seemed to be higher. And this is for overall mortality, and it may differ if you look up a specific cause of mortality. But again, in Oklahoma, it's between 20 and 40%, and that trend is also seen nationwide. I believe the nationwide study cites 40%. Next slide, please. So how do we address racial misclassification? So these are some more general ways, and they are not exhaustive. First, we have to understand that racial misclassification exists and that ultimately it is an issue of data integrity. When you take individuals from one group and place them to another group, then the data are off in more than one group. Second, what we do is we use enhanced mortality data when possible. And this is sort of like a Band-Aid, and it doesn't correct for all racial misclassification. Like you saw in the previous slide, there was an enhanced linkage done on vital statistics record. But this has not been done consistently, unfortunately. It's a linkage that's done by the CDC in conjunction with IHS. And the last linkage was done in 2020. Before that, I believe 2018 and then 2015. And we've been trying to advocate for more consistent linkages. However, most state departments do have these data, the enhanced link data set up to 2020. And in Oklahoma, we're fortunate enough that our health department's online data query system actually includes a tab where you can query for those data. And we're currently exploring more ways to get more consistent link data, as those data really reflect a difference. And I don't know if you've ever actually looked at those data, but if you have and you look at the outcomes before the linkage and the outcomes after, it is really eye-opening. And we've done a couple illustrations of that in Oklahoma to show the profound impact racial misclassification has on data sets, mortality data sets in particular. So I won't go into all the ways we're working to mitigate it in mortality data, but we do have projects currently that we hope are successful in doing so. But today I want to discuss why we looked at Oklahoma's Medicaid data and what we've done so far to begin to address it. Essentially, all the ways that we address it deal with thinking upstream. Now, there may be some epidemiologists on this call, and you're probably familiar with that term, thinking upstream. That's what we try to do, take steps upstream, to identify potential points where racial misclassification may occur. As a side note, the ultimate upwards point in the stream came after some listening sessions occurred with the communities we serve. We identified a real opportunity in self-advocacy and self-empowerment, and that led to an infographic on our website, getcountedright.org. So if you go to our website, getcountedright.org, you can see we have some resources available. We have a couple of infographics, and we also have a tab where if you have some resources that you would like to submit for racial misclassification, we would love to take a look at those and possibly include them on our website. So what led us to Medicaid data in specifically? Next slide, please. And I want to say that we looked at oral health Medicaid data. We go. A colleague of mine was frustrated that the National Centers for Medicare and Medicaid Services, the CMS, was othering American Indians and Alaska Natives in the oral health data. And othering just means they weren't just aggregated into their own racial group. They were considered other. And although Oklahoma had an AIAN population to support disaggregation, the CMS told her other states did not, so she could not get the data that she needed. So we decided to use an existing group that we attended regularly in Oklahoma called the American Indian Data Community of Practice, or the ADCOP for short. We used that group to recruit members and develop a racial misclassification or advisory group, which we call the RMAG, to explore the issue further. And next slide, please. So my colleague proposed that we do a map of data flow from when an individual enters the Medicaid system in Oklahoma and follow that record through the system to reporting those data publicly. And again, we looked at this for oral health. She happened to be on a webinar organized by the NPHL, or the Centers for State and Territorial Epidemiologists, the CSTE, presented this map. And that webinar was fantastic, and I think it's still available. After she told me about it, I was able to watch it and found it very insightful, and I would highly recommend checking that out. So it was at that point that we reached out to the NPHL, and they were kind enough to facilitate a meeting with us and another group who had done something similar with data mapping. And that's how we ultimately met Dr. Huey, who will speak next. But we looked at this map. If you see step one, it's a patient seeks healthcare services. Entities report the data to public health agencies. Public health agencies transform raw data into usable personal level information, and then agencies transmit data in cases notification to the CDC. So that didn't exactly fit what we were doing, but it was a very good start. And so we brainstormed about, is there anything else existing, and how would this look for Oklahoma? So next slide, please. After some research, we didn't see a lot of work on this topic or some examples that we might be able to adapt. So the RMAG decided to adopt this framework from the CSTE and start propagating the map for Medicaid oral health data in Oklahoma. So how does this look? How does Oklahoma data flow through the Medicaid system, or a patient's record flow through the Medicaid system, I should say? So the OKHCA is the Oklahoma Healthcare Authority, and they are responsible for Medicaid in Oklahoma. And Medicaid in Oklahoma is known as Sooner Care. So we looked at data flow from the patient into the Sooner Care portal, to clinics, to the OKHCA, and finally to reporting. Next slide, please. So this was a rough first sketch, and I want to add that this whole project is very much dynamic. We're still not finished, and we want to be able to modify the map as we gather more information. Additionally, we know policies and procedures are always changing, so this is fluid, and we're going to address and update this as we continue to gather more information. For our first draft, we just wanted to get as much information as possible and somehow organize and document that information, the information that stemmed from the hours of meetings, calls, and emails. We still had many questions after the sketch and continued with meetings, emails, and phone calls. So you'll see we organized it this way: a patient, and then they are entered into the Sooner Care portal. That data goes the Sooner Care portal, then clinics, then the Oklahoma Healthcare Authority, and then reports. That's kind of the flow of things in Oklahoma at our first draft. So next slide, please. So you'll see we gathered more information, added to a second sketch, and we still had a lot of questions. I feel like we really, I don't want to say bothered, but the people that we worked with on this were very gracious enough to help us because we had so many questions, so many emails, so many discussions. And one key discovery was even though a patient may be AIAN, they may enter the race as another race, not AIAN. We discussed the reasons for this, and I'll talk about those a little later. And that led to discussions around areas of focus of outreach and education, which was the intent of this map, to identify areas where racial misclassification might occur and ultimately look at ways to address it. Another key discovery was that the Oklahoma Healthcare Authority told us they've created an algorithm that factors things such as CDIB card, where the patient was seen, an IHS facility, for example, if they were affiliated with a tribe, and then a new tribal indicator variable is created. This does not change the race of the enrollee, but creates an entirely new variable. So, of course, we had many questions around that, like where is that new variable reported? Can that new variable be requested in a report, etc.? That variable was ultimately created to identify individuals exempt from a policy requiring recipients of Medicaid to seek employment. The AIAN population was given an exemption to this policy. Next slide, please. So after more meetings and more questions, we redesigned the map. Now this map is in draft form, so I ask you, please don't share it. We still have a few things we're waiting to clarify, and the title is a working title. I know I need to have some hyphens in there somewhere, and maybe the legal team might advise me on that. So as we went through this process, we saw great value in it. And so much so that I've been advocating both within my organization and to other organizations to map data sets. It was something that always seemed, as an epidemiologist, very intuitive to me. I thought I understood, data flow in general, but once we got down to a really granular level, we really saw areas of opportunity to introduce some education, some resources, some advocacy, some outreach work to help mitigate racial misclassification. And so you'll see we have our list of acronyms down at the bottom. I won't go into each of those, but this is where we are right now. There's the patient and the way that race is reported, and it gets entered into a Sooner Care portal, and I'll talk a little bit about that on the next slide. Again, an area of outreach there, and we've identified some possible outreach, such as Good Health TV, which is an organization that runs information in tribal clinics and IHS clinics. Then there's the clinics, then there's the Oklahoma Healthcare Authority, and then there are ultimately reports. And that's another thing, is the volume of reports and the types of reports. Are they ad hoc reports? Do they occur regularly on the website? How are they requested? So there was a lot of information, a lot of questions. And again, things change over time within different agencies and different policies. And so again, this will be a very fluid, dynamic process. Next slide, please. So some insights that we learned and possible areas of outreach. Enrollment data and claims data are different. So many of you probably know that, but it's something I hadn't really thought through and exactly the implications that might have before I began this project. Enrollment data in Sooner Care are broken out by race in some report. However, claims data do not show race. And this in itself is another issue entirely that we are looking into. We've also learned that the patient may be AIAN, but not selecting AIAN. This may be for different reasons. First, someone may have entered the information other than the patient and misidentified their race. The patient themselves may have actually not entered themselves as AIAN, and this may be for several reasons. Some tribes require a blood quantum, and they may not meet that and may not have a card. So since they don't have a card, they select another race. We believe Oklahoma may be unique where sooner care is concerned. They do not require proof. It's through self-attestation. So you don't need to be enrolled or have a card. You just self-attest that you're American Indian Alaska Native to be counted as that in Oklahoma. This is not only important because different tribes have different qualifications, because historically, some American Indians chose to be removed from the rolls for their safety. We learned a bit about the process for catchment clinics and how their data is not directly uploaded to the Oklahoma Healthcare Authority, but to the OKPCA and then uploaded to the OKHCA. We're still unclear if this process is automatic or not. We also learned about this new tribal indicator that the Oklahoma Healthcare Authority creates. The new variable is very interesting. The CMS says they cannot report race for AIAN for the AIAN category due to low numbers, but these low numbers aren't from Oklahoma, but from other states. So if other states had that variable as a proxy, would they have the numbers to disaggregate race, or at least a new tribal indicator variable? Additionally, Oklahoma may also be unique in self-attestation and not requiring proof. If other states did the same, would that allow for disaggregation? So is this population being underreported? These are questions we'd like to explore more. And finally, we are hoping to discuss these findings and ask these questions with the CMS. We've reached out to them and they've agreed to have a meeting with us so we can discuss these things. Next slide. Thank you very much for being here, and thank you very much for inviting me.
Good morning, everyone. Sorry, I'm set up in a slightly different space than usual. But good morning or afternoon for those of you who are on the East Coast. Thank you, Shannon, for the introduction, and the NPHL for having put together this panel. My name is Brian Huey, and I'm an analyst with the Center for Health Equity in the LA County Department of Public Health. My work in our unit, among other things, involves developing equitable data strategies. So I work closely with our Chief Science Office, which is a unit that's responsible for our data policy and governing our standards of practice and so on. But my role is really to explore how we can grow beyond our existing standards and advance our efforts towards equity. Next slide, please. So today I'm going to discuss the riveting topic of data visualization. We'll discuss some of the current approaches to presenting race and ethnicity data, and we'll present, I think, the idea of inclusive data and why it's important. And then I'll present an alternative approach to visualizing inclusive data that seeks to reconcile both the principles of inclusion and some of the pragmatic realities of our work, how it exists today. So data visualization people will say that the most effective visuals can be grasped within 10 seconds. But that quick and intuitive grasp, I think, relies on some shared understandings, particularly around definitions, scale, and context. And that shared understanding can break down when you're trying to communicate complex ideas or data that could have contested meanings. For instance, racial identity. Next slide, please. And so that brings us to bar charts. I promise I won't just talk about different types of charts, but bar charts are one of the most intuitive ways to present data, particularly comparison data. The human brain processes the comparative length of bars, I think, faster than other types of charts. And so bar charts are everywhere. And particularly, they are kind of the approach to presenting, I think, race and ethnicity data and when you're talking about populations. And so this is really a common tool in fields such as public health and sociology and other fields that really deal with population data. And these types of charts are generally very effective at comparing groups or subgroups. But, and I teased this earlier when I said that charts can struggle with complexity, it's not that simple. The typical race and ethnicity bar chart has some important limitations in specifically in diverse regions or regions with a lot of racial and ethnic diversity. So next slide, please. So first, broad umbrella categories can mask meaningful differences in diverse jurisdictions. So this is census data, I think Census 2020 data from LA County. And so in LA County, the category Asian includes nearly 1.5 million residents, each with different cultural backgrounds and languages and migration histories, all of which are relevant to health status and health access and any number of other public health implications. And you can see here, this is just a smattering of the subgroups that are included within Asian, but here you already have 9 groups that all have very different kind of cultural backgrounds and health statuses and access to care and so on and so forth. And so while convenient for data tabulation, such groupings really may not offer the detail needed for community-specific program planning and hold even less meaning for members of the communities that they're really intended to represent. So if I'm trying to go out to the community and, conduct outreach on a public health initiative, if I go and I conduct all of my outreach in Chinese, well, you can see that that may hit whatever subset of this first bar is, monolingual in Chinese, but there's a whole lot of other folks that get completely left out of that approach. So these broad umbrella categories have limitations. Next slide, please. Also, people who identify with more than one race are often grouped into multiracial or other categories. So using catch-all categories simplifies the classification process. It makes it really straightforward. But it does not really reflect how individuals understand their identities and can diminish their representation in analysis and data products. And frankly, it may be the only common thread among the people in this category. So of the people who are 2 or more races, you could have any number of combinations in there. And other than having 2 or more races, they may have little else in common, which makes that not a particularly functional group, a functionally relevant group in a data product. And so as a result, these categories really become kind of de facto miscellaneous catch-all groupings that and their main purpose is to allow the total population tabulations to tally exhaustively, make sure that everyone has a place to go. Next slide. Communities with smaller population sizes or higher proportions of multiracial members can be underrepresented in published reports. And so you can see a couple of groups here where those numbers are pretty small. In practice, many reports present data only for white, Black, Asian, and Hispanic or Latino groups. And this leaves smaller communities such as Native Hawaiian and Pacific Islander and American Indian Alaska Native out of key visuals and summaries where visibility really matters most. And then furthermore, kind of artificially depressing population size by excluding multiracial members of groups and assigning them to a generic multiracial category erases not only the data that represents millions of LA County residents, but also the groups to which they belong. Next slide. And I'll have some examples of these further down. And then finally, externally imposed group definitions can create both ethical and practical problems. So many communities define their membership in ways that include multiracial individuals as full members. This is particularly common, or at least particularly the case in communities that were subjected to settler colonial projects. Imposing exhaustive categories carries ethical ramifications of disregarding a person's agency to self-identify and a community's agency to self-define. And then, moreover, just using exclusive group definitions can misrepresent the actual composition of these communities, which in turn can shape how needs are interpreted and assessments, priorities are set, and public health strategies are developed. Next slide, please. So the unseen cost of intuitive conciseness kind of reveals itself. Beyond highlighting health disparities, the practices influence who appears in public health data products and who may be left out. Next slide. So what is inclusive data? As we just saw, the basic bar chart obscures or even erases some identities. Alternatively, inclusive data approaches ensure that data collection, analysis, and presentation, or in this case, visualization practices represent individuals' full identities. Some of these inclusive approaches include data disaggregation, creating relevant groupings, and what we're going to be talking about today, the inclusion of multiracial population in each group they identify with. And so for those of you who work in public health or with population health data, it's not so simple to just change how categories are tabulated. There are lots of things to consider. I think Jamie kind of went through some of the challenges that they were having in Oklahoma, and making these changes. It also involves, kind of reflecting on our current practices. So next slide. So here we have two different approaches. We have the mutually exclusive and exhaustive approach, which classifies everyone in a single mutually exclusive category. This is the one that results in a two or more, or those sort of groups. And this is really the most common approach at the moment, and it has been for a while. We have our 6 or 7 basic groups, and everybody fits into one of the groups. And the inclusive any mention approach, its basic principle is that if someone identifies with a group, they are included in that group, regardless of what other groups in which they may or may not be a member. So this allows for individuals to be fully represented in the data and not recategorized into a generic multiracial group. And so the graphs we just saw are examples of the mutually exclusive and exhaustive. And in just a moment, we'll take a look at an example of an inclusive visualization. The next slide. But first, why am I making the case for inclusive data? Using and presenting data in ways that reflect multiracial identities is increasingly important. As a county and the country becomes more diverse, the tools that we use to analyze and communicate demographic data really need to improve to stay relevant. Our reports must keep pace with the norms of how the public understands racial, ethnic, and multiracial and intersectional identities, and presenting data in ways that align with how communities understand themselves helps to maintain clarity and relevance and public trust. And not to be discounted, our communities are asking for it, and they have been asking for it for a long time. And in fact, whenever we ask them, what do you want to see in data? This is what they ask for. Next slide. There are also arguments against moving in this direction. Totalization and rates. When you're including multiracial data under the exhaustive model, you end up with data that totals beyond 100% of the population, because what you're actually counting is 100% of the identities. Someone has more than one identity, it gets counted more than once. So this makes the math screwy. And this is different from how populations are tabulated and analyzed in a number of fields. And of course, to calculate rates, which are extremely important in fields such as my own in public health, when we're talking about public health measures, when you're talking about mortality, we need consistency between the population denominators and the health condition numerators, or the decedent counts, or so on. And this requires a lot of stakeholder coordination. There's a lot of cooks in the kitchen. You have labs, you have providers, you have health plans, you have the state, you have local jurisdictions, you have the technology involved, EHR vendors. There's any number of folks that are involved in this. So yes, that makes it really difficult to ensure consistent and high quality data. And then, as we've already said, we're really already set up to do the mutually exclusive and exhaustive. So we've been doing it for decades. It's easier in many ways just to stay. Next slide, please. But here's an alternative that we've developed, I think, to better present inclusive data. So in this inclusive race and ethnicity visualization, each bar represents one group, and shows the proportion of the people who identify, or I should say each row, horizontal bar. So each bar represents one group and shows the proportion of people who identify with that group alone, which is the dark blue, with that group in combination with one or more others, which is the light blue, and then also the proportion of the population who do not identify with that group at all. So it's kind of an out group. This structure reflects the full range of identities within each group, and rather than placing multiracial individuals into a single catch-all multiracial category, but by using a stacked chart within each category, it actually ensures that the total for each row adds up to 100% of the population, and while also providing an accurate visual representation of the multiracial population within each group. So this solves the math problem, and it also presents a more inclusive picture of each group. And depending on the quality and granularity of the data you have, you can get even more specific. So who in the light blue is a member of which other of those light blue bars? So you can start seeing the combinations, you can start seeing subpopulations within this visual. Next slide, please. And so here's the same data in table form. And this approach also highlights meaningful differences between individuals that identify with that group alone and those who identify with that group in combination with others. I think that there are some legitimate questions about, well, is this group taking the top row, American Indian, Alaska Native, we see 18,000 for the alone population, and the in combination populations over 300,000. So is that in combination multiracial population? Are those people encountering the same health issues that the people in the alone group are? Maybe and maybe not. But we have a starting point to start looking at some of those differences, and those differences, really may be relevant for understanding that community composition, health outcomes, service utilization, and program engagement. And this can also improve visibility and count stability for communities with smaller population sizes or high proportions of multiracial members. For instance, American Indian and Alaska Native, NHPI, you see that those numbers increase dramatically, which gets them onto the visual. That makes them, it includes them in some of these additional analyses. Next slide, please. So I have a couple of examples for you. Some of you may be familiar with the study by Case and Deaton. This article was quite important to establishing deaths of despair as a critical public health topic. It's also the rare case of an exclusively white health disparity. And to be clear, this is not a critique of the paper. I think that identifying this phenomenon was really groundbreaking and important, and it's resulted in lots of resources being directed to harm reduction services. So it's been really important. But I do want to demonstrate that even some of the most highly touted work can obscure important findings based on their approach to presenting data. So the key finding from this study was that white non-Hispanics were the only racial group to see an increasing mortality rate over this period from the late 90s to the 2013. You can also see, in the top row, that the only group to have the increase in mortality rate, 33.9 more deaths per 100,000. Both the other categories are seen to have decreasing rates. They have that negative value. So next slide, please. So here's that data in a line chart, which is not the same as a bar chart, but the point's the same. So I've taken some liberties here. The authors did not create this chart, but it's the same data. You get a little bit more from the chart than the table. In this chart, white is in the middle rather than the top. Yes, it's the only line that is increasing. It's this red line in the middle. It's the only one that's increasing, but the chart shows a different context among the other groups, right? Well, the group that created the chart actually featured it as a critique of the original paper. So if we can advance one more. So here's the full chart that was published by Friedman's group. Their group reviewed the data from the study period, but in this figure, you can see that whites are not the group most affected by the phenomenon, deaths of despair. In fact, they're not nearly as high in rate or rate increase as the Native American group, that purple line. It starts higher, it grows more and it grows much more quickly. And we can ignore the end. I think we all know what happened in the year 2020 that made mortality rates jump through the roof. But even before then, you can see the pattern is really quite striking. And so regardless of the reason that the AIN data were not included in the original paper, maybe it's the comparative population size. You know, there are 100 million more of the folks in that red line than there are in the purple line. But regardless, there are really substantive implications for the difference between the highest increase in rate and the highest total rate, and not even being included in the results on that original table. So my intention is not to single out this study for criticism. It's not a unique example. And I mean, on the second chart, NHPIs are aggregated with Asian, even in the new graph. That's still, I would imagine if you broke those two out, you would see two different lines. So the mutually exclusive and exhaustive approach really creates exclusion criteria for population groups, which can suppress numbers to the point where they no longer seem relevant to study results. So this is very common, and it's very common with small populations. Next slide. So in an example recently developed by my colleague Jerome, and I think Jerome might be on the line, so shout out Jerome. Everyone say hi to Jerome. Thank you for making these maps. They show the distribution of the AIN population by census tract in LA County. The choropleth shows population density of AIN individuals. The darker plots have a larger population of AIN. And so you can see that distribution mostly in the Antelope Valley. And for those of you not familiar with LA County, that's kind of the upper right-hand side of the graph where it says SD5. The East San Gabriel Valley, which is kind of where it says Ontario on the lower right-hand side, Pomona in Ontario, Long Beach in the south, and then I guess Malibu on the west. I'm not exactly sure about that, but that's how the distribution shows up for the AIN alone population. So if we go to the next slide, if you use the inclusive definition, the distribution changes substantially. You can see a much higher concentration in the Antelope Valley, the San Gabriel Valley, and Southeast LA. And you also see a pretty large population in the Northeast San Fernando Valley. That's kind of the top left-hand side or mid left-hand side where it says San Fernando, Santa Clarita, those areas up there. And this really, I think, is borne out anecdotally from, you know, our providers here in LA County and what we know of where our AIN communities live and congregate. So next slide. So side by side, these maps really seem to tell us something different about where we might focus a public health initiative that's been culturally adapted for AIN community members. Like if we're trying to implement something in the community and we prioritize based on the map on the left, we may have more or less success than if we use the map on the right. And so again, there are additional considerations involved when using inclusive approaches to race and ethnicity data. Does the increase in size and the change in composition of the group require additional disaggregation? Perhaps. That's entirely reasonable. I think that argument has been made, and it's a perfectly valid argument. As a proponent of disaggregation, I think that makes a lot of sense, and it's an excuse to do more of that. But regardless, you need a starting point. And in a county of 10 million people, it's a lot easier to edit 18,000 than it is to edit 300,000. Next slide. Oh, maybe I don't have a next slide. Well, in brief conclusion, this structure improves visibility for groups with high rates of multiracial identity. It provides more accurate and stable counts for smaller populations, and it supports clearer communication with communities and program partners. And so taken together, these improvements really help ensure that communities are represented more fully and accurately in data to inform public health practice. Thank you.
Thanks, Brian, Jamie, and Shannon. And we do have some time left over for questions, and I see it's been pretty active in the chat, so I won't have to use the questions I had in my back pocket. I'm going to try my best to just kind of go through and combine questions if I can. The first is, what did consultation and collaboration with tribes look like to collect tribal affiliation data? Did you need to go through legislation to collect this data? And then also another person asked, is it should they not be requiring a respondent to identify tribal affiliation when identifying AN data, or sorry, affiliation?
I'm sorry, could you repeat the first part of that? I was
Oh,
reading,
sure.
I read the wrong
Someone asked,
question.
no, so yeah, someone asked, I'm sorry, I'm probably confusing things by combining two questions. So the first one was, what did consultation and collaboration with tribes look like to collect tribal affiliation data? And did you need to go through legislation to collect it?
Is that for Brian?
I think it was for you. It was during your presentation. Yeah.
So I'm wondering what they meant tribal affiliation regarding, do they mean funeral or Medicaid data? Because that is dependent. You know, we have surveys that collect those data. We have on our funeral, the reporting that our funeral directors do, they have an area for tribal indicator. And as long as I've known, those have always existed, aside from a survey called the Oklahoma Prevention Needs Assessment Survey that actually collects tribal indicator. And that was something that was done with our organization to get that added to that specific survey. And they just partnered to have that added.
Okay. Okay. And I think that answers another question too. Someone asked whether the funeral home is the one that fills out the death record, not the coroner medical examiner. I mean, I think it could be both, right? Depending
Right.
on
And
the
that
circumstances of death.
that was another kind of one of those rabbit holes that we went down when we were looking at mortality data. Is I actually, in Oklahoma, we have medical examiner. We don't have a coroner's office. We have a medical examiner's office. I know some states have coroners. I actually put in a call to them and I asked them how they collect race. And they said that whatever's on the record when they receive the individual. And so that office does not go, I guess, unless maybe there is an investigation initiated. But it's just the standard that comes to them. And so I think it's, you know, even if a medical examiner collects the race, it's another fail-safe for the, because when you get the death certificate, ultimately a funeral director will fill out that death certificate information to you before it's submitted to vital statistics. It's another fail-safe. Ask the individual's family, ask whoever the person is with that with the individual that was deceased, ask them how that person chose to identify. You have an opportunity there. You also have an opportunity. I can't speak for other states, but in Oklahoma, if there is an error on the death certificate, you can go and have that changed.
Thank you. This one is, I think, directed at you too, Jamie. Can you describe a little bit more the difference between enrollment data and claims data in this context?
Yes, that was something that I just hadn't really paid a lot of attention to. You know, I hadn't dealt a lot with Medicaid data previously. And so when someone enrolls, it just means they've enrolled into the system. And they, you know, they determine whether they are eligible or not to receive Medicaid. And so those are those data. And so we have reports that this many are enrolled, this race and whatever. What we don't have, or when the person goes into a clinic and is seen and they submit a claim to get reimbursed to the Medicaid system, those data usually are not broken out by race, either at the state level or the national level. And the enrollment data that is reported out by race, what we found at the national level, American Indian, Alaska Natives are not disaggregated and they're othered, what we call othering. I don't know if that made it any clearer or.
Did for me. So, okay. So the next one is, and this is for both of you, if you, either both of you could talk a little bit about the tension between the need for disaggregated data and then the privacy concerns that it also raises, you know, particularly I think in our current political climate, but also just, you know, that's always been the case when you're dealing with small populations or small numbers, the risk of re-identification goes up.
I can start on this one. And I'm not sure I have really inspiring answers for you on this. I think that though they are potentially in tension, particularly right now. And it's a major source of concern for those of us who are working in this area. And not just for race. I think that there's a lot of concern about sexual orientation and gender identity data on, I think race, if anything, is potentially to be used as a proxy for immigration status or some sort of immigration law enforcement action. And, you know, taken in combination with other sources of data, it could potentially, you know, be compromise somebody's privacy. And there's also, I think, concerns about, you know, the types of services received and whether data kind of more broadly, health service data more broadly is secure. These are major considerations, and I don't know that we have some real firm solutions right now. I think that kind of where those of us who are working in the space are caught is, you know, at the moment we have some momentum and we have some resources to modernize our data infrastructure in a way that we haven't in decades. And as you all know, like the computing power that we have now just far outstrips what we've had in the past. And so like, it seems like it's an opportunity that we can't pass up, while at the same time, like, we need to be thinking about ways to ensure that folks consent to the way that their data are used. And I think we're learning, as you know, particularly in the last few months, about our assumptions about places where this information is safe and where maybe it's not safe. In terms of re-identification, you know, outside of the actual, you know, health data, but in population data, I think that there are concerns about that too, right? A lot of our you know, AI tools could potentially match up large data sets and serve to re-identify people. That's a big reason why we have the differential privacy measures that are placed on census data. Well, there's concerns about whether those measures are going to continue to remain in place, or what the quality of our census data is going to be moving forward. So that's a really long way of saying, yes, I think everyone working in this space agrees that there are very real concerns about data privacy and data security. And we're kind of like, our considerations are really, do we think about how we can address those needs as we do this work, or do we walk away from something that we've been advocating for decades and just say, well, we'll try it again sometime down the line when our immediate concerns are a little bit less scary.
Jamie, did you want to add anything to that?
No, that's a great answer. It's a fine line between protection and getting the information you need for the communities you serve. And we are very aware of the protections that are needed, and we take that very, very seriously. That's all.
Thank you. Yeah, no, that I'm sure you are. Okay, so the next question, this person asked specifically about the collapsing of AIAN and NHPI, Native Hawaiian Pacific Islander categories into a single category, and their preference that it be actually broken out. And they asked for recommendations to justify this disaggregation to their EPIs and statisticians. But I mean, I think you could actually make that more broadly with any kind of category. So, you know, last thoughts on like, how would you speak to your EPIs and statisticians to encourage them to disaggregate data more?
Brian, do you want to take, that's just something that we, you know, I work at a tribal epidemiology center. And so that's something that we always try to do, is to disaggregate, you know, American Indian, Alaska Native into their own category. But Brian, you serve a much broader population.
I'm sorry, Megan, I was trying to find the comment. Can you read that one more time?
Oh, sure. Let me scroll up now and find it again. The person was asking about their request that AIAN and NHPI categories be disaggregated, and if you had recommendations for justifying this disaggregation to their epidemiologists and statisticians.
Oh yes, I think that there's a lot of really important reasons to disaggregate. So I mean, even outside of, you know, like big number population stability, if you're trying to do, you know, statistical analysis, but even if you're just trying to look, I think if you look at these groups and try and break them down just kind of within their own context, you'll see that there's tremendous diversity within them. So starting with NHPI, there's a number of different Pacific Island, Native Hawaiian and Pacific Islander groups that are present in the United States and in specific jurisdictions. In LA County, we have Native Hawaiians, we have Samoans, we have Tongans, we have Marshallese, we have Chamorro, and some of them are American citizens, some of them are US nationals from American territories, some of them are foreign nationals of varying immigration status. There are lots of different reasons for each of those, mainly our colonial impact in the South Pacific. But that also has implications for access to services. If someone's a US citizen, they have different public benefits that are available to them than a foreign national or even than a US national. There's also some groups that have that are free compact associated areas that have like specific health benefits that are available to them because of, you know, for instance, nuclear testing that, you know, may have spread cancer to certain parts of the Pacific and things like that. So there's lots of very substantive differences in both health status and access that are relevant in these spaces, not to mention, you know, linguistic access and things like that. So there's that right there for Pacific Islanders is a really important reason to disaggregate that group. On top of that, among American Indian Alaska Natives, I think that probably most of the Native folks on this call or folks working with Native organizations know just how diverse a group that is. The census and OMB and some of these other groups, first of all, it's not just US tribes. Also, it's inclusive of indigenous peoples from Central America as well, and Canada, which there's different public health implications for being, again, for being someone who's across that border. It's funny the way that we talk about it, because these are colonial borders that we have introduced that have broken groups apart. And within the United States, tribes have different access to resources. They have access to IHS services. They have different expectations and respect to their sovereignty and treaty rights than groups that are not US tribes. And that also includes groups that are not federally recognized. So I think that these are often fraught conversations. There's also, you know, when you're talking about tribes, you're talking about political membership and you're not just talking about race. So they get really complicated. But it's important, I think, because these differences are ones that have practical implications for the communities involved. It just doesn't make sense to be talking about these groups as if they're monolithic, because there's so much diversity within them that they really need. Providing any sort of thoughtful engagement requires having a better understanding of that.
Thanks. Thank you, Brian. I think you answered a few questions there, so I appreciate that. And we are at time, so I do want to be conscientious of people's time and thank everyone for coming, and a huge thank you to our amazing speakers. Yes, so and the webinar, the recording and the slides will be available in a few days, so you should get an email about that. Thank you again. Hope everyone has a wonderful day.